Welcome, everyone, to today's deep dive. We are jumping into a medical field that is, I think, often underestimated in just how critical it can be. Dermatological emergencies. I mean, this is a topic that requires really rapid systemic action. And for any young practitioner or, even a curious learner, knowing these protocols can be the difference between life and death.
That's absolutely the mission today. We're diving into a really comprehensive medical text, a guide that's tailored for those on the front lines.
Medical students, residents.
Exactly. People who need to quickly get their head around a really complex and challenging area. The whole premise of our source is that these conditions are clinically, diagnostically, and therapeutically just intense.
Yeah.
They demand a focused, immediate approach.
Okay, let's unpack this then. Let's get right to the core. We're going to be looking at three crucial areas. First, defining acute skin failure, or ASF.
Right.
Then understanding the infrastructure needed to manage these patients, which includes this concept of a Dermatology Intensive Care Unit, a DICU.
A really key concept.
And finally, breaking down the management of severe cutaneous adverse drug reactions, or SCARs. So before we even get to the crisis management part, the sources really stress that time saved in diagnosis is, well, survival gain.
Absolutely.
So for someone facing a patient whose skin is just rapidly failing, what foundational diagnostics do we need to prioritize for speed and accuracy?
We have to move beyond just saying, oh, there's a rash.
Right.
We need a systematic and really swift categorization. The focused exam starts with defining the lesions. Are they primary lesions? The basic physical changes caused directly by the disease itself.
Like a blister or a macule.
Exactly. Or are they secondary lesions, so changes that happen as the primary ones mature or heal, like crusts or erosions? That initial sort immediately narrows down your differential.
And since so many of these emergencies involve blistering or peeling, the key question becomes, how deep is the damage? Is this superficial, or is it, attacking the basement membrane?
That's the million-dollar question. And we rely on two classic physical signs to answer that, right at the bedside. The first is the Nikolsky sign.
Okay.
This is when you apply a little lateral pressure, a slight shearing force, to skin that looks totally normal, right next to a lesion.
And it just peels off.
It just slews off, exposing an erosion. So skin that looks structurally okay is actually deeply compromised.
Wow.
A positive Nikolsky sign is a huge alarm bell for massive epithelial fragility. You see it in conditions where the split is superficial, like pemphigus toxic epidermal necrolysis, or 10N, and staphylococcal scalded skin syndrome.
And the second sign?
The second is the bullous spread sign. This helps confirm that the cleavage plane, so the location of the blister, is high up within the epidermis. It often points you toward pemphigus. Getting that depth right immediately dictates the urgency.
I found the source's differential diagnosis tables really fascinating because they force you to triage immediately based on very simple criteria. For instance, just the distinction between generalized blistering with fever versus without fever.
That small detail is the entire triage roadmap. It's everything.
What? Really?
Yeah. If you have generalized blistering with a fever, you are immediately thinking about systemic, potentially infectious processes.
Like varicella or something.
The disseminated varicella, purpurifulminans, yeah. Conditions that need immediate isolation, aggressive sepsis protocols. But if the blistering is generalized without a fever, you lean more toward autoimmune conditions like pemphigus vulgaris or bullous pemphigoid.
Which means the systemic risk is still high, but the immediate need for, say, broad-spectrum antibiotics might be lower. It gives you a slightly different investigation path.
Correct. That initial sorting tells you if it's immediate ICU admission for acute skin failure, or if the patient can be managed with, say, 24 hours of observation. The systemic involvement, not just what the skin looks like, determines everything.
Right, here's where it gets really interesting, because acute skin failure is just catastrophic.
Yeah.
When that massive epidermal barrier is lost, it creates a systemic crisis. It's almost like a massive burn, right?
It is. It's very similar. The body loses its primary regulator, and the consequences just cascade. Let's start with altered thermoregulation. Yeah. With all that denuded skin, you get massive, unregulated cutaneous blood flow and incredible heat loss through evaporation.
So they get cold fast.
They rapidly become hypothermic. And to counter this, they have to dramatically increase their metabolism, which is incredibly costly energy-wise.
So the body's just burning through energy to stay warm, even in a normal hospital room.
Exactly, which is why an artificially high ambient temperature is so vital. And if you see hyperthermia instead of hypothermia, that's a huge red flag. It often signals a massive interleukin-1 release, or worse, sepsis.
Okay, what's next in the cascade?
Next are the profound changes in hemodynamics. The widespread vasodilation, all the blood shunting to the skin, it dramatically increases the cardiac output. We're talking 2 to 3 times the normal rate.
That's a huge burden. I mean, how does the heart handle that prolonged stress, especially in an older patient?
Well, it creates a state of high output cardiac failure risk. The heart is pumping furiously, but perfusion to your vital organs, the kidneys, the liver, can actually go down because of all the shunting.
Wow.
And making this worse is the widespread capillary leak and edema. Factors like VEGF, VPF, they increase capillary permeability everywhere. Fluid just pours out of the vessels.
Which means even though the patient is losing tons of fluid through their skin, the fluid you give them intravenously might not even stay where it's needed.
That is the critical tightrope walk of fluid management. And it leads directly to the fourth failure, pulmonary complications.
Yeah.
Patients are at high risk for aspiration, ARDS, and crucially, pulmonary edema.
Right.
The sources are so clear on this. They warn that in the frenzy to replace external losses, overzealous fluid correction will rapidly worsen that capillary leak and drive the patient into overt pulmonary edema. It's a very, very difficult balance.
Given all these catastrophic failures, the fluid shifts, the cardiac demands, it's clear why a standard ICU approach might not be enough. And that's where the idea of a Dermatology Intensive Care Unit, or DICU, comes in.
Yes, the DICU needs to be a tertiary care capability. It's all about meticulous, defined, supportive care. Simple, practical things first. IV access. You have to insert lines immediately over uninvolved skin.
To avoid contamination.
To avoid contamination.
Yeah.
If the BSA involvement is massive, a central line is mandatory. And second, temperature control is paramount.
Okay, so what are the target temperatures? Why is that 30 to 32 degrees Celsius range so non-negotiable?
The room has to be maintained between 30 and 32 degrees Celsius, which for the staff is uncomfortably warm,
I bet.
but it's life-saving for the patient. By keeping the ambient temperature high, you minimize that evaporative heat loss from the skin, you stabilize their core temperature, and most importantly, you reduce the catastrophic metabolic expenditure.
That really puts the caloric demands into a frightening context. They're literally burning thousands of extra calories just staying alive.
They are. Prognosis is initially calculated using the rule of 9 for body surface area, or BSA. More skin loss equals higher mortality.
Sure.
But managing that energy deficit is key. Fluid resuscitation requires crystalloids. The formula is typically 2 ml per kilo percent BSA of detachment, plus another 1 to 1.5 liters a day for ongoing losses. Totals can easily hit 3.5 liters a day.
And the calories. We must be talking massive nutritional support.
Massive. To prevent the patient from entering a catabolic state and to fuel skin regeneration, calorie requirements progressively increase, often reaching 3,500 to 4,000 kcal a day.
Wow.
And nutrition has to start early, often enterally, because any delay just severely impedes healing and increases that infection risk.
Okay, let's pivot to severe cutaneous adverse drug reactions, SCARs. These are the life-threatening allergic or immune-mediated responses. And the most feared is the SJS10 spectrum. How do we quickly define where a patient falls on that line?
The definition is simple but brutal. It's defined purely by the percentage of epidermal detachment. Stevens-Johnson syndrome, SJS, is the milder end, less than 10% BSA.
Okay.
The SJS10 overlap is 10 to 30%. And then toxic epidermal necrolysis 10, or Lyell syndrome, is when detachment goes over 30% BSA.
And once you cross that 30% threshold,
The mortality risk just skyrockets.
given this is a reaction to a drug, the most crucial first step has to be just stopping the cause, right?
Absolutely. The first non-negotiable step is the prompt withdrawal of the offending drug. You have to stop the ongoing insult, and this can mean discontinuing potentially life-saving medications.
Which must be a really difficult decision.
It is. Clinicians often use tools like Shear's initial assessment, the 5Ds, to guide them. Diagnosis, drug exposure, differential diagnosis, determining causality, and determining severity and mortality.
And for a definitive diagnosis to rule out mimics like SSSS, what does the histopathology actually show in SJS10?
Histopathology is essential. The characteristic feature is full-thickness keratinocyte destruction right along the dermal-epidermal junction.
Okay.
The entire epidermis is essentially dying and separating from the dermis. This deep split is why 10 results in such severe scarring, especially on mucosal surfaces. It's a stark contrast to SSS.
And the biggest long-term risk for these patients once they're stable?
Infection and sepsis. period.
Mm.
The deep, large erosions are perfect entry points for bacteria. Lesions are commonly colonized by Staphylococcus aureus early on, and then that often shifts to Pseudomonas aeruginosa and other gram-negatives. Sepsis is the overwhelming cause of mortality in SJS.
Now let's talk about DRESS, drug-induced eosinophilia and systemic symptoms. Because while it's also a scar, the mechanism and the cause of death are profoundly different.
This is a critical distinction, especially for medical learners. DRESS usually has a delayed onset, weeks after starting the drug, and the mechanism involves complex genetic polymorphisms.
Meaning some people just can't process certain drugs?
Exactly. They can't adequately detoxify certain metabolites, like the urine oxide metabolites from anticonvulsants or sulfonamides, so these toxins just build up.
So unlike 10, where massive skin loss leads to sepsis, DRESS is less about the skin surface and more about what's happening internally.
Precisely. While the skin reaction is dramatic, the major cause of mortality in DRESS is organ involvement, often the liver, but also the endocrine system, pancreatitis. Recognizing that shift in risk from sepsis in 10 to internal organ failure in DRESS, it changes your entire monitoring protocol immediately.
And once we identify the drug and stop it, what's the goal of the disease-modifying therapy?
The goal is to halt that runaway process of keratinocyte apoptosis. Treatments usually involve systemic immunosuppression,
Steroids, things like that.
systemic corticosteroids, cyclosporine, or IVI. The data on which is best varies, but the point is, supportive care buys you time for these agents to work.
Okay, moving to some really practical, condition-specific examples that highlight that meticulous attention needed. Let's start with epidermolysis bullosa, or EB. This is a lifelong mecanobullous disorder. The source had a very specific, almost counterintuitive instruction for parents on blister care.
Yes, and this is a major teaching moment. In EB, the skin is so fragile that blisters form constantly. Parents have to be taught to never deroof a blister.
Never take the top off.
Never. Instead, they pierce the blisters with a sterile needle or lancet from one end to the other, allowing the fluid to slowly drain out.
Why is leaving the roof so crucial?
Because the blister roof becomes a natural biological dressing. By draining the fluid and flattening the roof, you create a protective layer over the raw dermis. It reduces pain, minimizes secondary infection, and promotes faster healing.
That's fascinating.
And for daily care, it's only soft cotton, loose clothing, and non-adherent dressings. Vaseline gauze, Mepitac, any kind of adhesive dressing will just tear the skin off when you remove it.
That level of fragility is unimaginable. Now let's go back to SSS and contrast it with 10 one last time, because clinically they can look similar, but the management is a whole different ballgame.
It is. SSSS, or staphylococcal scalded skin syndrome, is purely toxin-mediated. It's caused by exfoliating toxins from Staphylococcus aureus. The key is the pathology. While 10 splits deep at the dermo-epidermal junction,
Right.
the split in SSSS happens much higher up within the granular layer of the epidermis.
Which explains why SSSS heals so fast and without scarring. The basal layer is still intact.
Exactly. And clinically, SSS presents with a really characteristic facial appearance. Separation of the crust around the mouth, leaving these radial fissures, and periorbital crusting. Because it's a bacterial toxin, the immediate treatment is targeted anti-staphylococcal antibiotics like cloxacillin.
Finally, we talked about the risk of long-term scarring. What is one small, simple intervention that practitioners can do for mucosal care, which is so critical in SJS and Tunyan?
The mucosal involvement can be just awful, especially on the genitalia. The practical measure is preventing synechiae, the joining together of opposing raw surfaces.
So they don't heal stuck together.
Exactly. For the female genitalia, for example, you apply white soft paraffin ointment twice daily to any opposing erosions. This simple step prevents the surfaces from fusing during healing, which would otherwise cause severe permanent scarring and fibrosis.
So what does this all mean? I think this deep dive really confirms that dermatological emergencies demand desticle. We recognize they are not just skin conditions, they are rapidly progressive pan-systemic disorders. The skin is the indicator, but the failure is internal. Massive fluid and caloric drain, severe hemodynamic stress, profound infection risk, immediate meticulous supportive care temperature, nutrition, fluids, has to run parallel to specific therapy, like drug withdrawal or antibiotics.
That's the crux of it.
The skin may be the surface, but the consequences are deeply systemic.
And this raises an important question for you to consider as you synthesize all this. We discussed the massive need for fluid replacement in acute skin failure, but we also emphasized extreme caution. Given the nature of that capillary leak syndrome and the hemodynamic changes, why is overzealous fluid correction still so dangerous? And what major pulmonary complication does the source explicitly warn against, forcing clinicians to walk that very, very fine line?
Something to mull over as you prepare your own approach to critical care. Thank you for joining us for this crucial deep dive, and we hope this knowledge helps you navigate these high-stakes scenarios. We'll see you next time.